Ladies and gentlemen, I'd like to call this meeting to order. This is the regular meeting of the Mojave County Board of Health, June 9th, 2021, and our first meeting since January because of the COVID pandemic. So I'd like to start out with asking everyone to stand and join us in the Pledge of Allegiance. And Clerk of the Board is trying to get my attention. Do we have someone on the phone?
That's what I'm trying to verify. Can you hear us on the phone?
Parent.
Okay, go ahead.
Okay. Could you join me in the Pledge of Allegiance? I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation under God, indivisible, with liberty and justice for all. Okay, do we have any members of the public that would like to speak? This is our time set aside for call to the public. Huge. Okay, seeing none, I will close the call to the public and we'll go on to the business to come before the board this evening. The first item would be a discussion of possible action regarding the pandemic update, and we have Denise Burley ready to give us that report.
Okay. Shows my skill in slideshow. Of course, there's a security alert. Okay. All right, thank you. Welcome back. It's always nice to see you all, and it's very nice to see you all in person again. I'll go through at least some highlights of our response for the pandemic. The PowerPoint that I'm going to put up is really more just some pictures that we had along the way, and in your packet you will find a 3-page document named Pandemic Response Update with the exact information that I'll be going through. So this was an incredibly busy year for us, as you can imagine. We started off on February 1st opening up our Health Emergency Operations Center, which we have in as a space within our office space, which has computers and big screen TV and so forth, so that we could communicate and coordinate and plan our response from that particular room. On March 22nd, we had our first official case in the county. We had some false starts as far as cases prior to that. You probably read the media, and I think at that point we were trying to ensure that we were getting information before the media was. Sometimes a little tough competing with Facebook, but we managed along the way. So we had our first official case on March 22nd. We then convened our emergency response team, our ERT team, which included the Department of Risk and Emergency Management. At that time, we started setting up very regular meetings so that we could communicate very quickly and very frequently. As you know, the information was changing very quickly out in the science and in the public, so we needed to stay abreast of everything and try to ensure that our response was appropriate for the conditions that we had in our community. Immediately after, of course, that first case came in, our nurses began investigating all the cases and doing contact tracing. They did this for quite some time, actually, up until the point where they couldn't do it any longer because of the sheer number of cases that were coming in. It was completely overwhelming those internal resources. We also, during the spring, started accepting orders for PPE, the personal protective equipment. As you know, hospitals, healthcare facilities, long-term care, and skilled nursing facilities were all finding themselves in a bit of a bind with some of that PPE running in very short supply, and also the cost for that type of equipment was off the charts at that point as well. And we were receiving supplies from the Strategic National Stockpile in addition to ADHS. So those resources were coming through to our warehouse, and then we would then take orders from these facilities, and then we were actually delivering them to the facilities to ensure that they didn't have to spend any resources doing that. So we had staff that were assigned to do that as well. We were also at the same time developing a web system to keep the public informed of cases, deaths, and some of the median conditions in the community again. So we were working with our IT staff to develop the coronavirus response hub, and then over time you saw that evolve and evolve and evolve with more information as we got it, and as we got more information that we could actually share. When we have small case numbers in a small community, it really is, it's not appropriate for us to share that information out. And we needed to wait until those numbers were high enough, really, that we felt comfortable that a person could not be identified as a result of that. Let's see, the governor's executive orders came into play about this time as well, where there were some businesses that were closed and others that were, their operations were scaled back. This was the stay-at-home order. This was a fairly challenging time, of course, for us because our agency received most of the complaints from the public about those businesses that were not complying. We were instructed by the board at that time to use some of our resources to go out to these facilities and investigate and inspect the facilities, and at that point really just providing education. We were trying to help them understand the governor's executive order, what it meant for their business, and try to get them to comply voluntarily. And I just got a message from Cal, so let me take a look. Can I ask you to work with Jeremy?
I'm on it.
Okay, all right, cool. Hi, Cal, thank you. So that was a step that our environmental health staff took on because they were already working with a lot of this population. The challenge was we have spent the last couple of years really building up those relationships with those businesses so that they don't see us as an adversary, that they see us as a partner in trying to improve their facility and the health of the community overall. And so to go in with sort of an enforcement mind definitely set that back a little bit. And we'll spend the next year or so building that back up and ensuring that we have that positive relationship with those businesses. We worked with hospitals and some of our federally qualified health clinics, and then Embry to bring testing to the community. As you know, there were very limited testing resources. There were an abundance of those in the valley and in some of the larger populations, but not here. So we were very persistent, if you will, with trying to get some of those resources to our community. And Embry did eventually contract with Mojave Community College at each of their 3 locations in the Tri-Cities area and place a testing site at those locations. And then they ran some very long hours. So it was very, very helpful. It made it very convenient to get tested, and that's really what we needed. We didn't want obstacles and barriers because people made their own decisions at that point about what was important or what they needed to do. And by getting a positive test result, we would follow up with all of those cases and give them the guidance that they needed to move forward. We, at that time, also received an Abbott ID rapid testing machine. Now, the false negative test results for many of those are pretty high. And so we opted to use that particular machine with the long-term care and skilled nursing facilities because we could easily and quickly identify positives, and we can get them into quarantine and isolation situations and work with the staff from that point forward. So that was something that was, it was, a difficult decision of some sort to really accept that machine, knowing the 40% false positive test results that you knew were the potential for that machine. But knowing that we were also going to just use it for that purpose really provided us with a resource that we wouldn't have had otherwise and would have had to wait days to get test results for. So that was very helpful. And of course, at that time, CDC's recommendations around masks and social distancing, physical distancing came out. And we were, of course, following suit and aligning ourselves with CDC's recommendations, and always throughout the whole pandemic, aligning ourselves with the science of the virus and making sure that we were following that guidance that was best practice. Any questions on our late winter, spring? I should state that for a number of us, this was our entire job. We did virtually nothing else for probably 6 to 8 months, and maybe longer if I actually sat down and thought about it any further. And most of us were salaried employees. Were putting in easily 50 to 60 hours per week, and sometimes above that, to make sure that the work was getting done. So it was our commitment to the community. It was our commitment to all of you. And I felt like everybody stepped up to the plate and really went over and above what anybody would typically expect in an emergency situation, because normally those emergencies are more short-lived. They're generally speaking, maybe a few weeks, maybe a few months, but a year plus was a little bit more than any of us really anticipated. But
Denise,
yes,
excuse me. I just wanted to say that I personally, and I'm sure everybody else, want to thank you and your staff for all your dedication and hard work. We know that you put in a lot of hours, and just to keep up with all the demands and the changing situations. And you were awesome. Thank you.
Thank you. Yeah, my staff deserve a lot of the credit. I mean, we worked as a team to get this done, and none of us could have done this on our own, and there was just a lot of teamwork involved, so it was very, very helpful. Thank you.
Okay, Denise, I'd like to mirror what Marianne said. You did a great job under the pressure of 5 members of the Board of Supervisors who at some times were quite agitated and actually a little on the mean side. So I never saw any real tears, but I know they were there informing, and I thought you kept it together pretty well until you got out of this auditorium. So good job,
Yeah.
Denise. And how are we doing now?
You know,
I mean, we're not out of the woods yet, but we're on the downside.
we're actually starting to see our numbers increase again.
Oh, thank you for that correction. I
Yes.
guess.
So what you're seeing for the last 2 weeks is an increase in our case numbers. Now, a little bit of that, and I do mean a little bit, is actually a result of older tests being brought into the system, but we're talking maybe like today's report was 45 cases, I think, and 5 of those were old, the other 40 are new cases. So the majority of these cases are still new, and what you're seeing in the deaths now are younger ages. So we still need to be mindful that there are a number of people in our community who are not vaccinated, some for personal health reasons. They're unable to receive the vaccination. Some, it wouldn't be effective. Other people make a personal choice not to get the vaccine. And so we need to be mindful that the virus is still in the community and it can still be spread. And so we have you, for example, in this situation again. So, I'm hopeful we can not see some of the increases in cases that some of the other countries are seeing as a result of some of the variants. Yes.
Quick question. Do you have any data so far as our case positive that you can share with us for the whole year, see where we're at in the trend for the county? And then my other question right now is the rate of vaccination for our county. And third would be some place have incentive to help, community get vaccinated. Would that be something? If our number is so extremely low, maybe we should consider that. So.
Very good point, Dr. Nguyen. Our current vaccination numbers are fairly low as far as fully vaccinated in our county. I think we are, and Melissa, maybe you can help me out, because I think I was planning to bring in your report. Do you have that? by chance? During the meeting, we'll find that information for you. I apologize. I really did mean to bring it in because we have a spreadsheet that we maintain, and we do it by age group, so we know what percent of the 65 plus. Oh, there we go.
Fully vaccinated is 32.84.
Can I borrow this? Thank you. So, yes, so 32.84% of our population is fully vaccinated. Where we're, of course, most concerned, or at least where we were originally, is the 75 plus, and we have 76% of the 75 plus have received at least one vaccination. We do know that all of those long-term care facilities and skilled nursing facilities that had signed up for the federal program did receive that service through the federal, through Walgreens and CVS. So those facilities did receive the vaccination services, and that was completed. For the 55 to 64 population, we're sitting at 45% have received at least one vaccination. For the 45 to 54%, or for now, see, I'm getting my percents, slow down. For the 45 to 54-year-olds, it's 31% have received at least one vaccination. 20 to 44-year-olds, it's 20% have received at least one. And then less than 20 is 12%. So we have a ways to go, I think, to really reach that herd immunity, or even close to that herd immunity stage. So.
Just another observation. It's interesting, a lot of dynamic with this virus. For example, like the flu, most of the health institution mandate the worker to be vaccinated unless they have a right reason. But with this virus, it is not really mandate. Across the country, there are some institutions, they mandated it. So it's something for us to think about. At least that group, this virus attack a lot of healthcare facility, nursing home. So I really hope that we would have, at least as a start, to have that trend for the future, because I believe it might come back just like a flu virus. Again, that's personal thought and observation of what's going on.
I do believe this will be endemic at some point here, probably coming up in this next year, where we're just going to see it cycle through, similar to what we see with flu, where we're going to need either booster shots. The question is how long out. Nobody really knows that at this point. They're testing that as a result of the vaccines that are currently available. And in those cases, they may be able to modify the vaccine to meet the challenges of the variants that exist in that time. So, okay, so yes,
I just want to say that you personally, your group personally, helped me out in a sort of living house situation where I had COVID in the house. And I will tell you, your nurse was exceptionally wonderful, professional, and I was so relieved to know that she was in the picture and could help those gals in the house. So thank you for that.
that's great to hear. Great to hear.
Thank you.
Yeah. So summer and fall, as you know, summer we had our first spike, and that's when our resources for our nurses and trying to keep up with long-term care facility cases, because the nurses took on long-term care facility cases and school cases all the way through the pandemic. And we hired hired and trained temp investigators to take care of the kind of general population cases. But when you're dealing with the long-term care facilities, you really need the expertise to help them understand how to mitigate the risks and ensure that the facility is taking the appropriate steps as well. And then with the schools, you often have administrators, parents, of course, and school nurses to navigate through, and it's important to have your key staff on those cases to address those questions and concerns. We also hired a temp epi staff person to help us with some of the data As you know, there was a lot of data coming in at that time and trying to figure out how to present it to the public. As you know, the system, the way it's structured and how the state reports it was different. We were working on different timelines. We were being asked to report information on different timelines really than how the state reported, so our numbers weren't aligning, and that caused a little bit of concern and confusion for the staff and for the public, I realize, because they're trying to figure out whose numbers are correct. So thanks, then. Yep. Okay, all right. Then we also really got into the real enforcement piece. We were asked and instructed to put together a enforcement strategy, and with the help of County Attorney Knudsen, we did that, and that particular process actually had some enforcement teeth to it. But it also was a path to compliance. Our goal was not to be heavy-handed with that approach. It was really to provide the structure so that they knew what it would look like and what we would be doing at each particular point in time, and that really enforcement in its truest sense was a last resort. And I think the staff really took it on the chin, especially our EH staff that were out, because we only followed up with complaints. So we didn't go to every business and try to reach them. We certainly didn't have the staff to do that, but we did go out to, as we got a complaint via phone or email, that would go to EH staff. They would send an inspector out within a designated time frame. We do that initial inspection. Virtually, well, so probably, I'm not going to give a percentage, but most came into compliance after the first visit. So we had that. There were just very, very few that we actually had to follow the path down to actual almost shutting a business down, but we never did. So that never did occur, and I think the staff really did everything possible to ensure that we got to a point of resolution without that. We did have a schools team, and so we had a team of staff that were responsible for being the kind of a conduit for information and resources for schools, including participating in the school superintendent's meetings each week to provide updates and information, to answer questions from school superintendents, and also act as a resource for them. And if they had questions that they were unable to answer, they usually come back to our staff, and then of course provide that information back to the schools as necessary. So, all right, then we moved into winter. I think that was probably one of our biggest challenges yet, where our case numbers went up dramatically over the holidays. As a matter of fact, they went up so quickly, and thankfully ADHS stood up resources at the state level. We sent a number of cases on to the state, because even between our staff, our temp investigators, they were unable to handle that load of cases. So fortunately, they hired about 600 case investigators for the state, and we were able to basically push those off to the state, and they took care of those cases, because we would have never been able to follow up with all of them. Would have been impossible. At that time, we also developed our vaccine task force, because we knew vaccine was going to be coming out, so we needed to start planning for what that was going to look like and how we were, what our role would be in this, and what resources we had available, in addition to how the onboarded providers would receive their vaccine and move forward. So we initially realized we weren't going to be able to, we didn't have the resources. We could combine resources with the other like National Guard and CERT teams. We could combine those resources, but we also knew community to community that would look very different. So we did run a dry run exercise out at the fairgrounds here. We had probably 40 to 50 people out there volunteering, and we ran it just as if we would run a regular pod, so we'd understand where we had gaps and what we needed to fix and what resources we needed, and then realized that through that process that we didn't need as many resources as we thought we would. So that was definitely a positive for us. But we also recognized we would be stronger if we were partnering with some of our onboarded providers and agencies out in the community, and that's where the Safeway partnership came up, is that they had an interest in, and they had experience in doing these types of drive-through activities. So we partnered with them and also brought on National Guard resources to help us do some of those large community pods that you saw in each of the communities, and tried to measure our resources and combine those to be effective at getting at least about 500 people vaccinated at each site during the given day. So very effective partnership, and a big thank you to Safeway and their team for jumping on board and their willingness to get involved in that. Okay, I don't want this, I know this could take up an entire meeting, and so I want to make sure that I'm available to answer questions also at the end. We also developed an onboarding vaccine ordering process. Now, the way it was structured is the onboarded providers could not initially order their own vaccine. All the vaccine was, so the county would receive their allocation. So ADHS would say, you're going to get X number of doses of this vaccine and this vaccine. And we had an order form that people would submit, the onboarded providers would submit, and then we basically had to figure out how to divvy up that resource among all the communities that were requesting it, and try to be fair to each community percentage-wise, knowing what their population was. And sometimes it was splitting hairs, you know, it was how many ways can you split up 3,000 doses in 5 communities, including Beaver Dam, Littlefield, and Colorado City, and then the 3 cities, and knowing that there were also little providers in some of these communities that we needed to make sure had some. But staff did, again, an excellent job of trying to make sure that everything was fair and equitable, and that it got to all the different communities in a way that was meaningful to them. Let's see. Currently, we, of course, continue to monitor cases and deaths and report out vaccination numbers and try to look at the trends. We support the onboarded vaccine providers with information. We assist with transferring vaccine when we can. We don't actually facilitate the transfer, but if we know, for example, a facility reaches out to us to say we have vaccine that may be expiring in the next, 3 weeks, we reach out to all the onboarded providers and say, can anyone use this resource faster? So we're trying to minimize or eliminate the waste. And if we can do that, more power to everybody. And then communication, just overall, initially we reported every single case out to the media and to the county manager and to the board. And that stayed that way through the weekends even. So that meant we were all on call every weekend to make sure that we were getting that information out to the public in a timely manner. And then we transitioned to once per day. Yay, go us. And that was important, I think, because we were all so busy doing other, having another piece to the response that was taking up a pretty fair amount of our time. And now we've scaled back to just the 3 times a week for some of that information. We continue, of course, to try to keep the board, county manager, and the public up to date with important information where we can, and we'll continue to do so and for the foreseeable future. So, any questions?
Any questions?
I have about 1 million, but I'll talk to you later.
Yes, I can totally understand that.
Denise?
Yes, hi, Cal.
So with the increase in cases, have we looked at that throughout the state and regionally?
You know, I didn't have a chance to actually compare ourselves to the state numbers. Lynn, do you happen to know, are cases higher compared to the state or about the same, or is the state seeing an increase as well? Okay, great. We'll look that up. Easy enough.
Thank you.
Mm-hmm, absolutely. Any other questions?
Denise, can we have a conversation, maybe not right now, today, but about what we could have done as a board to support you through that crazy, crazy year? Because I felt like I wanted to help, but I didn't want to bother you either. So, and I know I wrote you several times about issues that I had and encountered in the community, just so that you would know what was coming from a different kind of public, usually the healthcare public, because I've been a nurse for 45 years, so that means everybody thinks I know things that I didn't know.
Yes.
So I felt like there was something we could have been doing that we weren't doing as a board. So
Right. Yeah, I think, we will eventually get to a point of getting our team together and doing a after-action report and just going through, basically, we did one already because we knew that enough time had elapsed, we're going to forget some of the details. And so we completed one in September, I believe. And then we need to do another to kind of go back through and say what went well, what didn't, what would we do differently, what would we change, how would we involve different people in this. The one thing that was really crystal clear to me, and it's hard for the public to understand, is infectious disease data is not intended to be reported out daily because it changes. And in the public's mind, change means manipulation. It means that we're unsure or something. It doesn't, in the public's eye, always mean that it changed because we corrected it so it was right. I mean, that was the goal, is to have accurate information out there. But that data, you would see in some cases, I'll give you an example of a different county, they would have a case count for each community, and then it would say +1, 0, -1, but that number would change and it wouldn't add up the way people would say 2 + 2 = 4. That's not how infectious disease reporting works, because one day you may say, well, this case was reported in our county, and then the next day you learn that that case wasn't our county case. So it gets subtracted out of our account. But, that's not easy for people to understand of why did a case get moved out of your count. So challenges all across. But I think there's absolutely a room for that conversation to occur, and should.
The virus really affect the rural communities severely. Compared to other rural community, how are we? Do you know that information offhand?
Yeah, there were certain specific communities within the county that were harder hit than others. And certainly there were some rural that fell into that for sure. Yeah. Okay.
Okay, so ready to move on to the next item? Number 2, the discussion of possible action regarding the workforce development plan revisions.
Okay, thank you. Thank you. Good evening, everyone. I'm Melissa Palmer, Assistant Health Director, and today I'm going to be going over our workforce development plan revisions. In your packet, you do have our current version of the Workforce Development Plan. Our Workforce Development Plan, it's there to identify training to build skills in our staff to ensure that they have what's needed to perform at the level that we need them to perform at. It sets a culture of learning, identifies the web-based versus in-person trainings, and then it provides the specific source for all of the trainings so that way everybody's getting the same information from the same location. And it's required for accreditation. So, lost my spot. So our workforce training document was first created in 2015 for our accreditation process. And we found that there were many changes that were needed. So we began the process of updating it. This is a picture of the 10 essential services, and the arrows pointing at the build a diverse and skilled workforce, which is part of our workforce development training plan. So in public health, we look to ensure that we're using quality improvement in all areas, including our workforce, to ensure that any gaps that are there are filled, that any knowledge that's missing, that we're able to get staff the knowledge that's needed to fill their roles. And it provides opportunities for development. It also provides the foundation for new staff joining the health department. And here's accreditation standard 8.2.1, which is maintain and implement and assess the health department workforce development plan that addresses the training needs of the staff and the development of core competencies. So in our workforce document, we have identified the training required for grant programs, for licenses, registrations, certifications, for emergency response, and then those courses that build a robust workforce for our health department. We want to make sure that we have a healthy foundation for our staff. And then also the trainings that are needed for staff who are new to public health. Oftentimes we get staff in that are hired that are completely new to public health. They've worked in the private sector, they've worked with hospitals and other healthcare providers, and public health has these nuances and differences. So these trainings actually help those individuals to understand what public health is and the role that we play in our communities. So we had a strategic work group that started working on this document in anticipation for reaccreditation, and that team started working on this document in November of 2019. So we got through 3 meetings before COVID hit. But we did have key staff that dedicated themselves to ensure that this document was completed before our reaccreditation process. So I would like to thank those individuals. Updated highlights. On page 4 of the document, we updated our current workforce demographics. In 2015, we had 84 employees working for us. And in 2020, which is where these numbers are coming from, we had 78 individuals working for us. And that was pre-COVID. So currently we have about 10 COVID employees that are temp staff working just the COVID response. So our full-time, well, we have some that are part-time and half-time, especially in senior programs. Those individuals all are included in that 78 count of our employees. And then on page 6, we updated the domain and tier items for the core competencies, and those were pulled from the Public Health Foundation. So they updated their core competencies, and we updated them in our document. Pages 9 through 43, those are all of our trainings that staff have to take upon hire, or if it's added in as an additional item that is added to either a grant or program, or we added in a diversity and cultural competency course, which then our staff will take those courses as they are added on. But for our brand new staff, this is the list of trainings that they receive upon hire. Now, we do have a nice spreadsheet where their particular trainings are listed. It's not the entire page 9 through 43. That would be completely overwhelming. Some of these are for environmental health only. Some are for nurses only. Some are for our nutrition, our WIC program in the Nutrition and Health Promotion Division. So we do have a spreadsheet and a checklist for those roles that we can hand them that, and then they can go and complete those trainings. A lot of these trainings on pages 9 through 43, they had broken links. They were no longer in existence. We rely a lot on universities or public health foundations to have these trainings available to our staff so that we aren't having to recreate them. Sometimes they expire, sometimes they update them, sometimes they decide they're no longer necessary and they remove them from their website. So then we have to go and find substitutes for those trainings. And then lastly, we added in, like I said, the cultural competency, the diversity courses, we added those into the document. And then our very last addition was we had to update our health director. So we did that on page 47. Any questions on that?
Are the new courses that you're offering to your new staff and current staff, the cultural and diversification, are they taught in-house?
Those are not. We rely on outside individuals. We do have some things that are taught. Bloodborne pathogens often are taught by the nursing division. Sometimes we do have opportunities to do the cultural competency and diversity training in person, but because our staff, they're up in Colorado City all the way to Havasu, so we have to have something available for them if they come on board either right after that was offered or during a time of a pandemic where we can't get together anyways.
Thank you.
Mm-hmm. And if staff do complete trainings in person, if we have had an all-staff meeting or an opportunity has come up where they've been able to attend it in person, and on the list it's a web link, they still get credit for that. We don't make them go back and do both. Any other questions?
That's a lot of training.
And
I'm impressed. I really am. It's I had no idea that there was that much training required or even available to staff for this accreditation. So thank you.
public health
Any
is
questions?
so fluid. Public health is so fluid, and our community consistently changes. Look at what's happening right now. The diversity of the population is changing significantly from psychographics to demographics. I mean, you're seeing an influx of retirees, an influx of multicultural families. And who services them? You. And so I think it's incredibly vital that we're able to provide this, and I'm really impressed with the list and thankful that there is training available for public health employees who don't make enough money and service this community. And I just hope that they know how appreciative our community is of them. Maybe we need to do a better job. Maybe that's something we should come up with.
I have a quick question.
Yes, Dr. Wood.
You also have to take CEU every year, your continuing medical education.
For not all of our licenses and certifications require CEUs, but many of them do. And some of them, if they're offered through this, they can submit those as CEUs. And if there's opportunities for CEUs, either through conferences or other types of events that they can go to, then we do encourage that.
Do you have any compensation model for those to encourage provider to take those courses?
For our environmental health staff, we do. There is a step, if they come in at a certain step and they obtain those other experiences and certifications, then they do get to move up.
Just, yeah, that help encourage, provider to update. The cultural diversity is important. The other topic is mental illness. A lot of challenging cases out there, so we can encourage our staff to keep up, by incentivize those CEUs is very important.
Yeah, we do have a first aid mental health training, and we're doing that in person, and yes, we've worked around that.
Yes, because we all know it's getting worse after the COVID. It's actually manifests a lot more. We do see that.
Yes.
Thank you.
So although Arizona doesn't require CEUs, many of our hospitals in the area have policy that says that nurses, for example, need to have so many CEUs a year. But we don't. We have to follow the mandate from the state licensing board, I guess, nurses.
Yes, that's correct. But many of our nurses do participate in continuing education. And we do have one of our grant-funded programs that our nurses work in. It's a requirement to do continuing education in that. Yeah. So they do participate in that for that.
I don't doubt with everything that you do that I'm concerned about it, but as a state, I think we all should be concerned that we don't have a mandatory CEU for nurses. I'm licensed in 5. This is the only one I don't need a CEU in, so it's weird.
I think that's where we want to create incentive, right?
Yeah.
Give a stipend or some sort of
Something.
way. Something that way we encourage our provider to educate. So much information. You can see this package is a start and then things change. Yeah. To help and just to prevent one or a few situations, cultural diversity and psychiatric illness is severe. It's very important.
Okay, thank you.
Thank you very much. Next item on our agenda is number 3. This will be a discussion of possible action regarding the reaccreditation update.
Good evening.
Good evening.
Hi, I'm Barbara Hartnett. I'm also going to talk about the community health assessment and the community health improvement plan at the same time. So I'll be addressing items number 3 and 4 at the same time. I am the special programs analyst for public health, and I am the accreditation coordinator. And in June of 2016, Mojave County was accredited by the Public Health Accreditation Board, also known as FAB. We have now moved to the reaccreditation phase, and we will be seeking reaccreditation this year. We will be eligible to apply for reaccreditation this summer, and we'll do so around mid-September. I'll go ahead and talk about our reaccreditation efforts, and then I'll talk about the chip and chaw. Reaccreditation, next slide. There we go. Reaccreditation requires documentation and narratives which demonstrates public health's commitments to providing quality health care services to the community while seeking to continue to improve the quality of our processes, policies, and the services we provide. The application for reaccreditation will become available to us on July 1st, and we will have until September 30th to apply for to submit our application and to pay the required fees. Currently, I'm working to collect all the required documentation and narratives that we will need to submit once our application is accepted and approved. Once our application is approved, we will have 8 weeks to upload all of the documentation. And as Melissa had showed you earlier, there's 12 domains, and there's quite a few measurements per domain that we have to meet. So documentation will be reviewed by the board. Once we submit them, they'll give us some initial comments and suggestions, which will give us a chance to fix what they do find, if they do find anything that we're lacking. Once that 8-week period of uploading documents and narratives is completed, the FAB board will come out and do a 4-hour virtual meeting with us. They'll do a site visit. They will go over our submitted documents. We will be required to have folks in the office that can answer questions about the documents we submitted. People that have created those documents and stuff would be required to be in the site visit with the FAB board. After the virtual visit, then the FAB board's going to determine if we meet all the requirements to be reaccredited and to keep our accreditation, and will be a reaccredited public health department again. I don't see any problems with that. We seem to have all that stuff ready, so I think we'll be fine with that. Okay, so why do we want to be an accredited public health department? A public health department that's accredited strengthens the quality improvement of that department. Quality improvement is an ongoing requirement of the accredited public health department, and each year we are required to submit annual reports outlining our quality improvement efforts. That also strengthens our partnerships. We engage community partners as our advocates, and when we seek to work diligently to create lasting partnerships with our community partners, as well as across the state of Arizona. Because we are accredited, we are seen as an excellent resource for healthcare solutions by our community partners and Mojave County residents alike. We are partnering with KRMC, which is Kingman Regional Medical Center, to update our community health assessment and our community health improvement plans for the county. This partnership will allow KRMC to meet its nonprofit status, IRS requirements, and assist Mojave County with our reaccreditation efforts. Accreditation also increases our accountability. It allows the health department the capacity to carry out the 10 essential public health services and demonstrates the department's ability to achieve efficiencies and improve the quality of services to improve overall community health. Reaching and maintaining accreditation requires considerable effort and time and attention to the needs of our community. It also strengthens our resources as we're preparing for reaccreditation. The accreditation coordinator works with members from all divisions of public health to gather the required information for the FAB review. This collaborative effort strengthens the relationships within the department and gives employees more resources to tap into the accomplished department goals. It also allows the workforce to evaluate their work and identify and improve processes with an end goal to increase efficiency and effectiveness and improve the health of our community and residents. And finally, it allows us to identify and address our strengths and weaknesses. When we identify these areas, we can begin to address the root cause and make necessary improvements. This results in better health for our community and a more rewarding and satisfying experience for our employees. So next I'll address the community health assessment. The community health assessment is a requirement for reaccreditation, and we are going to partner with KRMC, who is a nonprofit hospital, and the CHON, the CHIP, which is the community health assessment, and the community health improvement plan are required to keep them in good standing with the IRS and to keep their nonprofit status. It is not a requirement for any other hospital in our county. In 2009, Mojave County and KRMC partnered to create the very first community health assessment for Mojave County, and a community health improvement plan, also known as a CHIP, was created for each of our major cities from that first community health assessment. We will continue this partnership with KRMC throughout the summer and into the fall to update our latest CHA, which was created and released in 2019. The Live Well Mojave Coalition was formed as a partnership between Mojave County Department of Health and KRMC to address the updating of our community health assessment and to create our newest community health improvement plans, which are also known as CHIPs. So community health assessments are data and community input from focus groups and surveys and contains over 150 data tables. And what is involved with creating or updating a community health assessment? We are in the process of doing that now, and what the Live Well Mojave Coalition has done is created a notification and interest survey which has been sent to community stakeholders. These stakeholders include healthcare organizations, school personnel, law enforcement, and government officials, to name a few. Once we have gauged interest and compiled a list of interested participants, we will send out community health assessment surveys to measure how the community feels are the most important issues facing our county. These results will be compiled into a new or updated community health assessment, and in this case, we'll be updating our 2019 community health assessment. The community health assessment is shared with stakeholders, partners, and community residents. After the community health assessment is completed and distributed to the stakeholders and the residents of the county, we will create a community health improvement plan based on the results of those community health assessment and community input. So what is the community health improvement plan, also known as a CHIP? The CHIP is a lot of goals and objectives for health improvement, and it covers the next 3 to 5 years, created from the data that we collected from the community health assessment. After the community health assessment has been updated, we will work with the community partners and the public on strategies to address their biggest healthcare concerns. Throughout the county, obesity, mental health, and which includes suicide, and food disparities have been identified as the biggest concerns for Mojave County residents. We will be conducting town hall meetings in 7 different communities with Mojave County residents to get their input and allow their voices to be heard and to offer suggestions on the best ways to address the health disparities our county faces. And how will we create this CHIP? The KRMC and Mojave County Department of Health will partner to hold 7 town hall meetings with the residents of Mojave County. We will visit Kingman, Bullhead City, Lake Havasu City, Dolan Springs, Beaver Dam, Colorado City, and Golden Shores. During these meetings, we will share the community health assessment data with attendees and seek their input on issues they feel are most important to address, and will ask for feedback on the best ways to address those concerns. Once we have compiled all the data from the town halls, we will use the CHA and the town hall data to create our latest community health improvement plan for each major city, which would be Kingman, Lake Havasu, and Bullhead City. The community health improvement plan will include measurable goals that Mojave County and the community can use to gauge the success of our collective efforts towards addressing important health-related issues. And what is the board's role in this? The Board of Health can help support the Live Well Mojave Coalition by helping to promote the community health assessment and the community health improvement plan efforts conducted by the coalition. You can also help by encouraging your family, friends, colleagues, and constituents to participate in the town hall meetings and to be held by the Live Well Mojave Coalition. The Board of Health can also assist the coalition as an advisory committee to the group. The coalition would like the ability to seek your opinion on health issues as it pertains to the community and residents. We look forward to partnering with you on our efforts. That is the end of my presentation. Was there any questions?
Anybody have any questions? Looks like you get off easy tonight.
I think so, which is good. It's my first time. I'm sorry? So once we have the community health improvement plan, it's a 3 to 5 year goal, and so we would be meeting regularly with the coalition to gauge, are we addressing those goals and things like that. So it's a 3 to 5 year plan. We should have that done by the end of this year, and we would be distributing it to the various cities.
Right. So essentially the 7 different, that is a difference. So essentially the 7 different town hall meetings would be held next year.
No, we're going to do that this summer. We're
Okay.
putting the schedule together now. The community health assessment should be done by September, October, and then we would go ahead and create the CHIPs from there, the community health improvement plan. So yeah, we should have that done by this year.
Okay, thank you.
And then that will fall into with our reaccreditation and help us meet that goal as well.
Right.
So yeah. Any other questions?
Righty.
All right. Thank you.
Okay,
Thank you.
And next item, number 5, would be a discussion of possible action to establish the Board of Health meeting schedule for the remainder of the 2021 calendar year and 2022 calendar year. Denise, what are your recommendations?
Well, your schedules are pretty full, so I think we're trying to pick a date or a day, a fairly consistent day if we could, that we could conduct these meetings quarterly again. So we would be looking at June, July, August, September. We would be looking at September as our next meeting. So I don't have any preconceived notion as to what that might look like, but we would be certainly open to Tuesdays, Wednesdays, Thursday nights, I think are ideal. Mondays, Fridays, obviously, those are really tough. Fridays especially. And we want to know if this time frame works for everybody as well. If 5:30 is a workable option, or if you prefer to have them earlier or later in the day. We also are working with our IT staff, for your awareness, to look at how we might be able to do this through Microsoft Teams so that you could be at your desk. We have to work on the public participation piece, of course, to ensure that there is an opportunity for the public to participate in the meeting. But with this new technology, it does offer us some flexibility in that. And that would, of course, help maybe if you were unable to travel here, that it would help you participate in a remote way. So we'd like to offer that in the future if we can work with our IT staff and get that finessed, if you will.
Denise, the Microsoft Teams, would they still be available via YouTube video?
Well, actually, they can tape it. So that's another detail that we need to work out with IT, is whether or not it would be through YouTube. You can record all Teams meetings, so we could do it that way and then post it. It wouldn't be live streamed, of course, at that point, I don't believe. So logistically, we need to work on those details to figure out how we can offer it, but we do want to try to offer at least a little bit of flexibility for those, if you have something come up and you're unable to travel, that we can have participation in a different manner.
So we could have a mix of in-person and Microsoft Teams. That way we could continue to have the call to the public should anybody desire to come and speak.
Correct.
Okay.
We're trying to offer figure out the same kind of conditions for our community meetings coming up for CHA and CHIP, because we realize that there are a number of residents where transportation may be a challenge, and we don't want that to be a limiting factor for people to participate in the meetings. So we'll be working on that.
Okay, so personally, any day is fine with me as long as it's in the evening at 5:30.
Okay.
So do any of the other board members have any preferences?
I can't do Tuesdays.
Okay. Oh, those board council meetings.
Council meetings, yes.
Yes. Okay. So if we look at September, Let's see here. The first week, we've got the holiday built in there, so I don't know that that's an easy week for everybody, squeezing 4 days worth of work anyway into 5. How about like the 15th?
I'm away till that day.
What's that?
I'm in Boston till the 15th.
Okay, all right.
And I'm on my way to Kentucky that day.
Oh, I'm
Okay.
only one, but just.
Does the third, well, this would be the 4th Wednesday work? That would be the 22nd? Does that seem to work for everybody? Sorry, Cal, what was that?
I won't be available the week of the 20th, so the 22nd won't work for me.
Gosh, you guys are a tough crowd. See, we're looking how many months out and we're still struggling to find a meeting time, right?
How about the 8th? Did you skip that for?
I did just because the holiday was in that week, but that's fine. I mean, we're all going to be at work, so will the 8th work, the first Wednesday of the month? Cal?
Yes, that'll work for me.
All right, so we won't skip that. We'll do.
I'm away, but that's, sorry.
She. Can we have you participate remotely?
Last year, so.
Chairman John, ooh, I almost called you
Chairman Johnson?
Chairman Bishop. But you could always call in, even the way it's set up now, you're still able to remotely call in if you're available.
Yeah, does Boston have?
Does Boston have telephone? I could. And I usually take my computer on my vacations, but that's why I have 36 days over my minimum vacation. So they're kind of making me go away.
Oh.
Plus, I'm a little crispy around the edges. No, I can call in on September 8th. I just can't call in the 15th because I'm in a plane.
Okay. All right, so let's go with September 8th. 5:30 to 7? And do you want to try to work with that would be the second Wednesday of the month? Do you want to try to work with second Wednesday of each month moving forward? Okay.
And we can always call in. I think that's the future. Just in case we had another pandemic hit us, we can do that.
That's fine.
No more pandemics. I need to retire before another one comes along, please.
Sorry, you joined us. And that's what happened.
Denise, while we're scheduling, could I ask Eugene Kramer? He didn't attend the last meeting. He's not at this meeting. Is he still a board member or?
His term expires in July. And I believe that would be whose district? Sorry.
District
Chairman
1
Bishop.
Supervisor.
Actually, I have the answer for that for you.
Thank you.
It's
Yes.
actually Supervisor Lingenfelter's district, and he is working on a replacement for Mr. Kramer, and that will probably be approved by the board next month.
Okay, and then we have a District 3 vacancy. Do you have any?
As far as I know, he has not submitted anybody for approval. We can ask him again.
Yes, so another question is whether or not we want to try to rotate communities. And I know that there's a desire to make sure that everything is filmed and that we have the YouTube experience or we have a way to record the presentation. But maybe with Teams, if we're able to use a Teams approach, that would meet that requirement and allow that public. And again, we need to make sure the public has that opportunity to participate. But I also feel like moving around to the different communities gives different people opportunity to participate in person.
Denise, do you know if the bylaws state you will do the rotating meetings, or is that just something you've chosen to do? Because if the bylaws state it, until those are changed, we'll have to do it.
I don't believe our bylaws state that we have to rotate communities. Thank you for that clarification. Yeah.
Also,
Hated the first time, last time, not twice, 2 times, right? That's-
and Bullhead could do it because we do have the council chambers and we do live streaming and everything else.
Could you help us navigate through that?
You could sure call the city manager and I'm sure he'll be able to help you.
I'll be in touch with Mr. Cotter.
And
Okay.
I will support you on that if you need me.
And Cal, sorry?
Lake Havasu can host as well. We have all the technology.
Okay, all right. So let's, we'll look at the availability of Bullhead City, and if their meeting room is available, we'll go that route. And Cal, we'll take up your offer on the following meeting.
Okay.
And we have worked with them for the Board of Supervisor meeting, so I can help you with that.
Okay, awesome. Great, great, great. Okay, so it looks like if we follow that path with our meetings, then we would be September 8th, and then we would do October, November. We'd be in December. It would be December 8th. All right, so at least that makes it easy for us all, right? Same date. And we'd be into March 9th. And then June 8th. And that would give us our next year's worth of meetings. Okay. Great, thank you very much.
And the next and final agenda item is items for the next agenda. And with that being said, we need to approve the minutes from the January meeting. So if we could have that put on the agenda, as well as probably the minutes from this meeting. Does
It was
anyone
January
have any
2020.
other items?
If that's the case, then I will make a motion that we approve the January minutes.
And it's not on the-
It's not on the agenda.
We'll put that on the agenda for the next meeting.
next agenda.
Because
Okay.
I got it.
And then the June 2021 minutes. I also think that at that point, we may be able to provide some updated information on the CHA chip process, if that would be appropriate.
Denise, on the next agenda, do we want to discuss whether or not we want to open it up for nominations or leave things as they are?
No, that's fine. I think we can open it up for nominations.
Okay.
Thank you. And then we can also provide an update on our accreditation efforts. Okay.
Yes.
Will there be any, I know that you have a plan to reassess what happened during this whole thing. And again, I just want to bring attention to what our role can be in any future crisis,
Absolutely.
especially a pandemic, if we can help in any other way other than.
Or if we can help by not being involved, one way or the other.
Yeah, something.
Yes, absolutely. Yeah, I do hope that we can have even a preliminary summary of our staff feedback and input at that time, because again, once time goes by, you start forgetting some of those details about what worked, what didn't work, and I think it's important for us to revisit all of that. I think we'll be over our PTSD by then. I'm just kidding.
You will?
I think.
God bless you.
But I think it's important for us. I mean, I don't anticipate we'll see another pandemic, but I also think that we've learned valuable lessons during this time about what we could do better, but what also went well. I mean, I think our team really came together and fought hard to do what was not just expected of us, but what we thought was important to the community. And we really, I think, did a great job in taking those steps. But I also think that when you have never experienced something, it never goes perfectly. You always have lessons learned, and you always need to think about how you'll apply those moving forward. And I think we have those under our belt, and we adjusted even along the way. As you learn, you adapt, you learn, you adapt, you learn, you adapt. That was our whole process, is use what information we learned to improve the next phase, the next step, the next piece to this whole project. So Staff did a remarkable job adapting along the way and getting us through all of this.
Thank you for your leadership.
Denise, could I ask for maybe an update on valley fever? It seems like it's ticking up in certain parts of the state. It's been on the local news channels, and last time I asked about valley fever, it seemed to not be prominent in this area. So I was just kind of wondering if there's been a change in our area because of all the new construction that's going on.
Right, absolutely. We'll provide an update there, and we'll try to have Anna here as well, Anna Scherzer, our EPI, to do a communicable disease update. Okay.
Does anyone else have anything? I'll entertain a motion to adjourn then.
Make a motion?
All those in favor, aye.
Aye.
Good night.
Good night.